Professor Hahn, sir, we are starting now. He'll just make an introduction for you, and then we can start, sir.
Okay. Thank you, Dr. Tapesh Bansal, for arranging this webinar. So the first speaker for today, the evening session, is Professor Hahn. Professor Hahn is a very well-known clinician and a researcher in the field of fluid and kinetics. Sir has previously worked as a full-time clinical anesthetist between 1979 to 1993, and then he has switched over to academics. He has served as a professor of anesthesia and intensive care at the world-famous Stockholm Karolinska Institute in Stockholm between 1997 to 2006. And thereafter, currently he's working as the research director at Södertälje Hospital in Sweden, with part-time professorship at the Linköping University. Professor Hahn's favorite topics have been the physiology and monitoring of fluid overload in transurethral surgery and kinetic modeling of infusion fluids. He has authored more than 300 scientific chapters, and he has edited 2 books about fluid therapy. So I think it would be a great opportunity for all of us to learn about fluid kinetics from the first drop till the last drop. Over to you, sir.
Thank you. So we turn on the
First, you have to put PowerPoint.
Yes, yes, sir.
Can you see it now?
Yes, sir. It's
yeah, good. All right, everyone. We'll start to talk about volume kinetics now, and for 20 minutes forward. So first, what is it? It's a whole body macroscopic method that can analyze and simulate the distribution and elimination of infusion fluids. And we have data so we can explain how all the fluids that are available clinically today, how they behave. And it has quite great similarities to drug pharmacokinetics. The main difference is that the conventional pharmacokinetics studies the concentration of a drug, and the effect of the drug is related to the plasma concentration. Volume kinetics cannot use that because we cannot determine the concentration of an infusion fluid in the blood, because the blood is mostly water. And an infusion fluid contains, the volume is water, mainly water. But we do have an idea here that as volume-wise, the blood consists of 80% water and about 17% hemoglobin. We can say that if the water content of the blood, if this increases, this has to decrease. So if we have dilution of this water component based on that we add water, then we can capture it by the decrease in the hemoglobin concentration. And that is what we use in volume kinetics. If we calculate the plasma dilution, here is one example in the 10 volunteers who have received 10 milliliters per kilo, so about 800 milliliters of volume, as you know, we call it. And we measure it in the individual cases. Here the thin lines, and we have a model average line. They receive it over 30 minutes. We can make some conclusions without really calculating that much. If we go back with this curve back to 0, so we assume that all the fluid was infused on a single second, then we would arrive at 0.28. And if we divide that dilution with the amount of volume that we have infused, that 0.29 divided by 800, that becomes 3,000. So 3 liters is the volume distribution of this volume fluid, as you see here. That's exactly the plasma volume that we assume is the average in these cases. And also we can, from the same plot, take out the half-life, which is the time it takes for this plasma dilution to be reduced by 50%. So this is how we can begin thinking about volume kinetics. But of course, if we have other fluids and other settings, it can be very much more complicated. It becomes complicated already if we infuse a crystalloid fluid, because then we have a distribution between a central space and a peripheral space. Here is a plot where we show the plasma volume expansion from 3 fluids. This is each fluid has been infused in 10 volunteers. As you see, it's a pretty good initial volume expansion. If we give 2 liters, most of it ends up at the end of the infusion in the intravascular space. Then it takes about 30 minutes for it to distribute across the extracellular fluid space, and then we only have elimination left. We can also take out different components of this, like here we have done the elimination rate. It's much slower for the isotonic cell line, as you see, and that's why the isotonic cell line is shifted a bit upwards in that curve. If we compare ringers and a colloid, we will get a plot looking like this. So if we compare 1 liter of ringers, we say that about half of it resides in the intravascular space at the end of a fast infusion. And we compare it to 500 meters of Voloven, we will get a curve like this. So the very good initial expansion of the crystalloid fluid will soon disappear due to distribution, and then after the distribution is complete, then we have only elimination. So by doing this kind of comparisons, you can compare the potency of different flows at different points in time. Eventually, the 2 curves meet, though, after 6 to 8 hours. Well, if we do volume kinetics during anesthesia surgery and intensive care, we need to use a more complex model because it is more complex here. So this is the model I use today. It contains 3 spaces: a central space, a plasma volume where the fluid is infused and where we have elimination by urine output, of course. And we have capillary leakage, and we have a lymphatic return. K21 is equivalent to the return of the distributed fluid back to the plasma, so that's a lymphatic flow. And we have a fast exchange interstitial fluid pool, and that is kind of the watery part of the interstitium. And we also have what we call the gel phase, which is here we call it a slowly equilibrating interstitial fluid pool. I will get back to this soon because this is what we sometimes call third space, and it's quite interesting. If we go into intensive care, it becomes very important. Now these spaces are filled up in sequence. So if we give a small amount of fluid, like you see to the left here, we infuse about 250 to 500 milliliters over 15-30 minutes. Then the fluid will distribute only in the central space. We have no evidence of even if it's distributed to the peripheral space, it leaves there very, very fast. So it's not a long time there. You need to dilute the plasma and increase the intravascular fluid pressure somehow to get this distribution. But if you infuse more, you see 500 to 1 liter, then you get the distribution to the peripheral space. And if we infuse even more vigorous fluid administration between 1 and 2 liters over 30 minutes, then we get also an opening up to this third space, which you see comes here. When does that open? It seems like it's not a straight distribution. It opens up when we have an excess fluid volume in the fast exchange space that's between 600 and 800 milliliters. So expansion when we infuse fluid 397 milliliters, you see there's no arrow upwards, and not even 856 milliliters, that's too small. So it expands only the fast exchange space. But when we come up here, it's like opening up something, so everything flows into very quickly into the slow exchange extracellular fluid space. All these are a series of cases that I run. I say every curve is about 40 to 50 patients or cases. So this is altogether about 200 cases, and all these are volunteers. so far. We'll turn to anesthesia soon. This is how it looks, and the importance of the third spacing is, can you see here, if we extend the time frame to one day, this becomes a very dominant fluid space after some time. So when the intravascular fluid expansion, the red line here, has subsided, we still have a lot of fluid here in the third space. And that can be very difficult to recruit. So when you have an intensive care patient, you want to de-escalate, I've heard about that phase, of course. Manuel Brain has explained it very well to me. That if you inject a diuretic at this point, it will take fluid from these two spaces, like the plasma and the interstitial fluid, the fast exchange space. They communicate quite easily and fast. So fluid will come from these two spaces, but this takes a long time to for this fluid space to be emptied. So you can have a confusing combination here of hypovolemia and fluid accumulation still in the body. And we don't know yet to date how to recruit this fluid, but it's a very important point, I think, and particularly in intensive care. So you see, the more fluid you give, the longer half-life becomes. If you give a small amount, the half-life is quite short, around 30 minutes. And then if you give more, as the fluid distributes to more fluid spaces, it becomes longer. Now, is there any change in this kinetic story when we induce general anesthesia? Yes, there are two important changes. And the first is a slowdown of the elimination. And the second is a slowdown of the redistribution of fluid with the lymphatic flow. And we'll take a look at, Lisa, what happens if we induce general anesthesia. The driving problem here, the driving force to all hemodynamic and circulatory changes is a reduction of the mean circulatory filling pressure, which is a driving pressure for the circulation. That decreases when we induce general anesthesia, and that in the first place, it reduces venous return. And as you know, that reduces cardiac output in turn. It reduces mean arterial pressure, and then all the changes with poor renal perfusion and poor urine output, it comes as a consequence of that. And when we have general anesthesia, we work with that. We have all the time to be to fight this the consequences of this drop in mean circulatory filling pressure. That's what fluid therapy is for. This is a figure showing what happens with the urine output if we infuse 1 liter of ring acetate in a volunteer. In a group of volunteers after 30 minutes, you see about 60% is excreted after 2 hours. But if we have a patient during general anesthesia, it's very much lower. And it means that the urine output is not a good measure of fluid overload, because the urine output is driven more of other factors. Arterial pressure is the most important. Old age makes the excretion go more slowly. And we also have the adrenergic status playing a role. Now, the inhibition of the lymphatic flow was shown in experimental studies and laboratory experiments already in the late 1980s. But if we put these hypotheses into volume kinetic analysis, and we have about 200 cases and curves, we can see pretty well the effect of this toxic effect has on fluid distribution in humans, in living humans. And this is how the return flow, the K21, the lymphatic flow, how it changes. If we integrate these two changes, the inhibition of the urine excretion and the inhibition of the redistribution flow, we get these curves. We have only 2 fluid spaces here that we discussed, not the third space. But the main effect here is on the urine output. That's very much decreased if we have anesthesia, and that pushes the volume expansion curve in the intravascular curve. And we give it here over 30 minutes too, but it levels off at an early stage and retains more. But the most of the fluid overload ends up in the interstitium here, because it has more difficult here to communicate with the anesthesia. So here the fluid going back from the interstitium to the plasma works very well. Here it works very poorly and is retarded, and that's why that curve is pressed upwards. Now, if we go to intensive care, we have one more issue to discuss, and that is due to that inflammatory mediators alter the interstitial fluid pressure. That is quite well explored in experimental systems and in animals. It appears to be many of these cytokines and agents that can cause a reduction of the interstitial fluid pressure. The most dramatic change we do have in acute burns, as you see here, the interstitial fluid pressure is normally about -3. And here it can suddenly be down to -30. So that means that it tracks fluid from the plasma. The patient becomes desperately hypovolemic and is threatened to life because of this. In sepsis, we know it goes down to around -10, but it still retains fluid in the interstitium and particularly in the third space. So that can be a very, very substantial fluid accumulation because of this accumulation of inflammatory mediators. We can take a look here at one case, one study that I've done here, because there are many diseases that have a pathological fluid distribution, not only sepsis. This preeclampsia. Toxicosis of pregnancy, and here I've compared women who are healthy with pregnant women and with women who have mild to moderate preeclampsia. If we do volume kinetics on this as a group, and we use covariate analysis to see what is the difference between the fluid distribution in these women, we can get a curve. It's a little complicated. Maybe you can have been confused by this, but this is the healthy women, the yellow one. This is the blue one. That's the pregnant females, and this is the group of women that have preeclampsia. And you see right away that VC is a bit lower here, so they are slightly hypovolemic compared to the healthy ones. And we can see that the urine output is a bit increased here in this group, at least in the beginning. They're not severely sick. I think if they would be more severely sick in preeclampsia, they will have a reduced urine output. But the big difference is here. There's no return flow. And this is what happens if we introduce a vasoactive peptide somewhere that reduces the pressure in the interstitium. Then fluid will accumulate there, and it will have very difficult to return. So here's the capillary leakage of fluid. You say that's almost on the low side. So that's not the problem. Here's the issue we need to fight. So volume kinetics can identify the level of the problem, and then therefore we can focus the attention to the correct pathophysiological mechanism. If we overhydrate patients, and I think this is particularly of interest in the intensive care, they get tissue damages. And this is pictures from experimental animals, experiments I did in the 1990s. And a problem when you get overload is that the heart gets quite damaged. So this is the normal cytoarchitecture. This is the cytoarchitecture from an overhydrated animal. You see it's pretty much damaged. And the myofibrils here in the heart is trespassed by lacuna. This is just water of fluid. And that makes the heart to work more poorly, it will become, we will see ECG changes and the patient may eventually die. And this is when we have overloaded the animals, at least by just about 10 to 15% of the body weight, then we see this. I don't have any knowledge about this kind of studies in humans. And I would be very interested in, you have pathological hearts that from people who have been under intensive care and who have died from this, that we can see if there would be the same problems with their hearts. Just a very few words about albumin. I would like to end up with this. There's no difference in plasma volume and plasma albumin concentration if we provide if we provide albumin in the same amounts with 5% and 20% albumin. There will be no difference, and we can see this if we just measure the hemoglobin concentration in volunteers, which we've done here. Give it over 30 minutes, about 200 milliliters of 20% albumin, and compared to 800 milliliters of 5% albumin, and then plasma albumin will be about the same too. So really 5% albumin is just 20% albumin where you have added a lot of saline. That's the quality of the fluid isn't that much difference. But if we want to go into detail with this, and we want to challenge how much fluid is recruited from the interstitium, can it really take interstitial edema away? Then we must apply volume kinetics, and I've done that. This is about 100 infusions of 20% albumin in different settings. Then you can quantify this and see how effective it is to remove peripheral edema. Okay, I would like to sum it up. Volume kinetics can quantify the distribution of infused fluid in the body, and it can make some level of, it can identify the level of the problem if you have some kind of maldistribution of fluid. I haven't done that so much here, but you can really simulate the outcome of infusions you haven't performed yourself, so it can be a predictive tool. Quantify capillary leak, we haven't talked about that, but that's another topic. But you can, of course, compare the potency of different fluids at different points in time. So that is what volume kinetics can be used for. And the final up, I'm sure you've seen this book is an iPad thing that is free for download. You just enter this title on the internet and you can download the whole book for free. I would like to recommend that, and I can mention that a lot of workers from India participated in this book. And finally, there's a brand new book here by myself and two colleagues from the US. Is more focused on hemodynamic monitoring during surgery, not so much about intensive care. So that's what's the end of my talk. So if there are any questions, I'll be happy to answer.
So thank you, Professor Hahn. That was a very enlightening lecture. Can you hear me?
Yeah, I must increase my sound a bit here. So
can you hear me, sir?
Yeah, I can hear you. I just want to turn up the sound a bit. So yeah.
Yeah. So that was an excellent and a very enlightening lecture on the physiology of volume kinetics. We'll ask the participants to type the questions in the chat box. In the meantime, if I can ask a question. So you talked a lot about the slow exchange space and the fast exchange space, right?
Yeah, these are quite new concepts and been around for that long, maybe 2-3 years or so.
Right. So as an ICU physician myself, so ideally we would just want our fluids to be restricted in the slow exchange space, in the fast exchange space, without filling up the slow exchange space, right? So often we end up giving like 30 ml per kg of fluid in the sepsis guidelines and all those things. So how do you think we should be tailoring our fluid therapy? At what point should we be stopping our fluids so that our fluid, whatever fluids we are giving, is just restricted to the slow exchange space, to the fast exchange space, and we are not just overfilling the slow exchange space and dealing with the consequences of edema?
Yeah, it's a really a lovely question. I mean, the main reason why we infuse fluid in intensive care and so on is that we want to volume expand the plasma, right? We also have other purposes if we do maintenance, we want to hydrate the whole body and all of that. But I haven't spoken about that. It's another topic, and I know there are many people who have been into that. And we want to hydrate the whole body. But here we are interested in having as much fluid as possible in these first two spaces, and the fluid overload. Security thing. The third space is a kind of overflow reservoir. So if we give too much, the body helps us really to not overload the plasma by pouring it into this third space. So it's helping us. That's at least that's my thinking now. The interesting thing is that it doesn't seem to be filling up forever. So you can come up to a limit, and then this protection ends. So this is under work now, publication actually, and then the fast exchange space seems to be filled again, and I expect that when this second filling begins, it's then we have this tissue damage situation. But it's quite interesting. What we want to have is a filling of the first two spaces, and we want to avoid filling of the third space as much as we can. However, understanding of the third space it can help us to understand why it can be difficult to de-escalate in the intensive care. Why you must do it slowly, and why if we make it too fast, the patient can be hypovolemic and hypotensive. So this, I think, it fits quite well into that picture.
Right. So if I could ask another thing, this was regarding the second part of the talk that you talked about, the return flow kinetics, right? So in the ICU, often we face patients who have come in with sepsis or septic shock. We have given them liters of fluid, and then we have a patient who is edematous, right? And in that situation, we want to improve the return flow kinetics. We want to take away all the fluid from the extravascular space, from the third space, and maybe from the interstitial spaces as well. So is there any way we can, like, apart from normally we would be using an albumin infusion with some diuretics, or is that the only way to go about it, or is there anything else that we can do to
really excellent questions, and this is really on front. We can say that we can say that the third space begins to be filled when you have expansion of the fast change space about 600 to 800 milliliters, and that is in a normal person corresponds to about 1.5 liter. And I think when you come up to about 2 liters of fluid, you should change a little to an adrenergic line to try to help the hemodynamics that way, and don't move on to 4 liters because it turn off, it just becomes edema, and the circulation doesn't get helped from that because it's locked off. It will be recruited during the de-escalation phase slowly, but it's not of help to your patient during the intensive care phase. So that's my conclusion. And if you can help the situation with hyperoncotic albumin in this phase, it's very interesting, and that's on front. I don't know yet. I performed many studies on 20% albumin during the past decade. And we tried it in different settings. We tested it in post-burn, and we've done so. But in this particular setting, when you have at the brink of fluid overload in the intensive care, and the third space begins to open, to use hyperoncotic albumin in that situation would be very interesting, and it could be a really good thing to do.
Thank you, sir. Is there any other questions from the audience?
Professor Hahn, sir, a small question from me. Earlier we had the Starling's law, and now we have the revised Starling's law with the advent of the subendothelial glycocalyx. So what is the main difference between the revised Starling's law and the Starling's law? And how is it going to make a difference to things?
Yeah, I didn't mention this because I have too short a time, but it's a very up-to-date question. Of course, we have the Starling principle, and we have the revised Starling principle. Some of the things that included in the new thoughts about the revised Starling principle are correct, and others I don't think are correct. But I mean, if we discuss these issues, first of all, it appears that they're right in that fluid that is distributed to the interstitium, it almost exclusively go back with the lymph. That's one thing, and the governing and the glycocalyx is mostly a barrier for leakage of albumin. I mean, if we infuse ringers quickly, it has very little or no effect if we have a glycocalyx or not. But if the albumin leakage is increased, then that will shift fluid to the interstitium. But that's a longer perspective. It takes hours to distribute fluid that way. Another point I want to make that I don't think has been really discussed much is that if we have increased capillary leakage for whatever reason, if you have increased capillary leakage of albumin or increased leakage of fluid, then the lymphatic return will increase. That's a way in a healthy human that creates a balance between the two systems. So if we have increased capillary leakage, which we do have to some degree, at least in sepsis or other intensive case, you need to have some other factor in my mind to keep it outside the plasma, and that could be in the intensive care that you use general anesthetics.
Thank you, sir.
Yeah.
If I could just ask one more small question. Sir, I was reading one of your papers and you mentioned about the volume expanding properties of colloids versus crystalloids under anesthesia. And you said that they really don't have much difference when the patients are under anesthesia. So at what situations if I understood it correctly, so at what situations would you prefer crystalloids or colloids over crystalloids in the perioperative period?
Yeah, I would suggest that we know, for reasons allergic effects and so on, that the first line fluid is a crystalloid, right? But we know that when we have come up to about 2 liters and 2.5 liters, things happen. We have adverse effects in the body. We have third spacing. We don't have only that. We have a slowdown of the gastrointestinal work. So we get a period of impaired gastrointestinal function after surgery, and so on. We have other adverse effects too. So we should change to a colloid when we have infused about 2 liters of crystalloid. So that's a way to reduce the total number of adverse effects of your fluid therapy. And that's during surgery. I don't think it can translate easily to intensive care. Obviously, in that setting, we get more over to adrenergic help. Yeah.
Right. Thank you so much, sir. Thank you for that lovely talk. We really enjoyed listening to you. So if there are no more questions, we'll move on to the next speaker. Is it okay, Dr. Bansal? We move on to the
Professor Hahn, thank you very much, sir. Very obliged for your time and hearing you. Thank you so much, sir.
Thank you.
So
should I turn off here or what?
Yeah, you can just